The topic for today's discussion is somatoform, illness anxiety, and conversion disorders, their identification and management. I believe for any clinician, the most gratifying experience, the most looking forward to experience for any one of us is always to relieve the patient's distress. To see someone who comes with a lot of suffering, with a lot of pain, with a lot of problems, and in any way if you're able to help them, and when they come next time and tell you that, doctor, the treatment that you gave me has really worked and I am so much better now. I'm sure for every clinician that is the most gratifying experience. And the converse is also true. When a person is not responding to treatment, continues to be in distress, and these group of disorders specifically, give us that kind of experience where, how much ever you try, you're not able to find what is going wrong, not able to reassure the patient, you're not able to relieve their distress. So let's see what exactly these disorders constitute, how to identify them, and what are the general principles of management. So we'll discuss a few case vignettes to understand these disorders better. So here is the first case vignette. It's that of a 42-year-old female who's married, is a housewife, and she's come with complaints of vague abdominal pain since last 6 months, sometimes gripping, sometimes of a burning nature, at times before eating food, at times after consumption. And she also has these peculiar complaints which she describes as gas, occasional heaviness, and also constipation. All this since the last 6 months. And now in the last 2 months, she also has some fresh complaints of heaviness in both her upper limbs, sometimes in the lower limbs. The site and intensity of heaviness, if you ask her, is variable. It's not fixed. And on examination, there were no evidence of any sensory loss, any motor impairments that were found. But she says that at times the symptoms are so severe that she's unable to carry out her household chores. And for these complaints, she has visited multiple doctors, including gastroenterologists, neurologists. She's also tried homeopathy, she's tried Ayurveda in the last 4 months. And almost all doctors, if you ask her, have told her that, there's no major abnormality in her gastrointestinal or the nervous systems. But didn't bring any relief to her, because she said that symptoms are real and you cure them. She has taken multiple treatment courses. Her symptoms would improve transiently with some, but would recur even while she was on medications. And she expresses a lot of distress due to these complaints. She's preoccupied about her symptoms and just says, I want a permanent cure. So this is very typical of a somatoform disorder. If you see the important features, the important clinical features which help us understand that or identify that this is somatoform disorder that we are dealing with, here are those. There are multiple symptoms, and these may involve multiple systems. In her case, we saw it was GI and nervous. They're often difficult to describe, so they often have a very vague nature. They often have difficulties in describing what exactly they're experiencing. The nature of complaints is variable. The sites are variable. It may keep shifting, right? And what is very important also is they don't seem to fit any known syndromes, known medical syndromes, right? And they go to multiple doctors, often called as doctor shopping, and it's very difficult to reassure them. So there are excessive thoughts, feelings, or behaviors related to these somatic symptoms. So they have these symptoms, but the story is not just about these symptoms. It's about how they react to it. They're excessively preoccupied with it. They're very worried about it, very distressed about it. And they spend a lot of time and energy behind, understanding these symptoms or relieving these symptoms, right? Now, what is important to understand is, somatic symptoms without any evident medical cause is not sufficient to make the diagnosis. Now, this is a very important shift in understanding. When we were using DSM-4, medically unexplained symptoms, this was important. This was a core criterion to diagnose these conditions. But a paradigm shift from DSM-4 to DSM-5 has been that you no more need this, right? So a person can have some symptoms which can be explained by some medical disorder and yet have somatoform disorder if these symptoms are disproportionate. If there is excessive worry, excessive distress, which is disproportionate to the underlying etiology, right? So medically unexplained symptom is no more a core criterion to diagnose these conditions. What is another important thing to remember is, just because there is no identifiable cause, right, doesn't mean the disease is not real, right? The suffering is very much real as much as any other physical disorder. So we need to validate their suffering. We need to understand that not being able to identify a cause doesn't mean there is no disease. It just means our inability to be able to find a cause for these conditions. In future we may be able to find, but at present we are not able to pinpoint and say that this is what causes these symptoms. It's just that routine tests are not able to pick up or not able to find out the underlying cause. Right. Coming to the second case vignette, this is that of a 24-year-old male who is single, is a software engineer, and since the last 1 year he comes with complaints of a burning epigastric pain which lasts for typically few hours, especially in the morning, he says, and this occurs for almost 5 to 6 days in a month. He takes some medications over the counter and for a week and then he is perfectly fine. What is bothering him is, he feels that he's having these symptoms repeatedly and he's worried that he may have a serious GI condition, maybe like cancer. And hence, to find out what exactly is wrong with his body, he has gone to multiple gastroenterologists, has undergone endoscopy twice, USG abdomen on 4 occasions, and 1 CT abdomen, and all this in the last 4 months. He's done multiple blood investigations, a hemogram, liver function test, renal function test, serum amylase, lipase, TFT, the entire panel. And all his investigations do not have any significant finding. He has been told repeatedly that there is no major problem in his gut, but somehow he doesn't feel convinced. He thinks that there is something missing, there is something that he has which is not getting picked up, and he requests for repeated investigations. In fact, he is now requesting for a biopsy to his gastroenterologist, and hence he has been referred to a psychiatrist. And this is what we call as illness anxiety disorder. In illness anxiety disorder, there's a lot of preoccupation with having a particular illness. Symptoms may be absent, or even if they are present, they are very minimal. And if a medical condition is present, as we saw for somatoform, even here the preoccupation is excessive or disproportionate. So he may actually have an underlying medical condition, but if you feel that his preoccupation, his worries are excessive, you may still go ahead and treat the illness anxiety. And there are excessive health-related behaviors. So going to multiple doctors, multiple investigations being requested. These are all features of illness anxiety disorder. Now you may ask, how is it different from somatoform disorder? Because in both the cases we see that there is so much of preoccupation with health, right? In somatoform disorder, we saw that the symptoms were involving multiple systems, right? And they were multiple, they were variable, right? In illness anxiety, on the contrary, symptoms are fixed, they're not variable, they're minimal, right? And they're limited to one system. And the preoccupation is not with symptoms, like in somatoform. But here in illness anxiety, the preoccupation is with having some illness or some underlying dysfunction, that is, something is going wrong with some organ or with some system. So it's not so much about symptoms per se, but it's about having some serious problem, serious illness, some dysfunction in the body, right? And another important feature you can say is they stress more on investigations. They stress more on finding out what is happening with them, as opposed to people with somatoform disorder who stress more on just relief of symptoms. They are not worried about, what's going wrong in their body or what illness they have. What they are worried about mostly is the symptoms. They just want a cure. And with illness anxiety, they are worried about what could be going wrong in their body. Right. Coming to the last and the third one, the case vignette 3. Here is a 15-year-old girl who is studying in the 10th standard. She has failed in her maths prelim exams. 2 days later, while she has to get her father's signature on the report card, she starts feeling very uneasy, very anxious. and starts falling down gradually. Following this, she was noted to have some jerky movements of both upper limbs, lower limbs, with uprolling of her eyeballs. This lasted for almost 15 minutes, during which she was partially aware of her surroundings. Following this, she regained complete awareness after 30 minutes, was completely oriented, and had some faint memory of this episode. Subsequently, she has had multiple episodes of similar kind. However, the nature of movements and involvement of limbs is variable. What is important to note here is there is history of seizure in the family, seizure disorder in the family. She does not have any history of fever, focal deficits, headache, no history of incontinence, tongue bite, or any major injuries during this episode. There's no history of confusion following the episode. And what is very important or very striking is she does not seem to be distressed about having these episodes. She was taken to a neurologist thinking that she has developed seizures, but her MRI brain EEG revealed no abnormal findings. She was referred to a psychiatrist. What we are dealing with here is conversion disorder. Right? Symptoms do not match. They do have neurological symptoms, but they do not match any known neurological syndromes. For example, in this case, if you see, it looks like seizures. But if you see the history carefully, there are so many pointers which will tell us that these are not real seizures. Or they are pseudo-seizures to say. So, what are the important findings is the first thing. She started falling down gradually. Right? With a seizure, the fall is quite sudden, it's quite abrupt, and people often sustain injuries. Right? She has not sustained any injuries, there's no incontinence. Right? Then she had this episode lasting for almost 50 minutes. A typical seizure episode doesn't last for more than 2 or 3 minutes. It's very brief. It's never so prolonged. Right? And a generalized seizure, person is not aware of his surroundings. He has no memory of the episode. In this case, she had some awareness. She had partial awareness of her surroundings even during the episode. And she had some faint memory of this episode. Right? And the semiology of seizure episodes remain the same in every episode. Right? This is unlike in this case. Every time she has this episode, the semiology is variable, right? The different limbs involved, different kind of movements involved, right? So that goes against a seizure, classical seizure picture, right? So that's the most important part of conversion disorder, right? And this feature may be there, may not be there, is labile indifference. In this case, it is there, but some patients may be quite distressed about the symptoms that they have. Right? So, in all these three disorders, somatoform or somatic symptom-related disorder, illness, anxiety, and conversion disorder, we find few things which are very common. One is lack of an identifiable cause. In all three disorders, if you see, you investigate them, you will not find any cause. Any identifiable cause. And even if there is some identifiable pathology, symptoms are disproportionate. Symptom presentation does not fit into any known syndromes, right? But what is important, as I have told before, is lack of an identifiable cause does not mean lack of cause. Why I am stressing on this is often because it gets interpreted by people, even by medical professionals, as lack of cause means there is no real illness, there is no real suffering. And we often try to belittle their suffering, try to think that they are feigning their illness. No. They are not feigning their symptoms, they are not feigning their illness. That is called as malingering, right? It is very different from these conditions, where the suffering, the symptoms are very much real. They are not consciously produced, right? So this is one very important take back message for all of you, is that though there is no cause, doesn't mean that the illness is not real. The illness is very much real, right? Okay. So yeah, this is the thing which I have already explained, that presence of somatoform illness, anxiety, dissociative feelings does not mean a physical illness is absent. And what this implies, we'll see in the management. Yeah. So coming to the general principles of management for these conditions, right? We first start with a detailed history, the nature of symptoms, try to rule in or rule out possible syndromes, right? And also take a note of exacerbating and relieving factors. Why this is important is also because I've made a note there. You go slow, right? There may be stressors which might exacerbate these symptoms, right? But patients may not readily acknowledge the role of emotional issues. So don't try to confront them. You just make a note of it. And one must also be aware that, a lot of times it's not just psychiatry disorders which worsen with stressors. A lot of medical conditions also can worsen with psychological stressors. So one cannot rule out based on just stressors that, one has a psychiatric condition or a medical condition. Stressors can worsen both of these conditions, right? A thorough physical examination, focus on symptoms involved, especially if it's the first consultation, first visit, do a detailed physical examination, right? And in subsequent examinations, one must do a brief examination again. This is to, ensure that, we're not missing out on some physical condition that is comorbid with these disorders, right? One must not get carried away by the hysterical presentation of these disorders. And if you feel from this investigation history that there is something which could be picked up in an investigation, one must go ahead without any hesitation, get the investigation done, right? Coming to the most important intervention that will be there in these disorders is reassurance. It is difficult to reassure them, right? But one must consistently try to do it. As Oliver Holmes has said, the role of physician is to comfort always, right? They may have a lot of difficulty in, accepting that there is no physical disease or there's an apparent lack of a physical disease, because that's what they're wanting to hear from you. So do not challenge, do not confront, right? But validate their suffering. Tell them that, I can understand these symptoms must be so problematic. They must be causing so much of problem in your day-to-day living, right? Why this is important is because the next point is very important. The role of pharmacotherapy is, if you have to go by evidence, it's very inconclusive. We do use some drugs, but if you go for evidence, there's not much conclusive evidence. And usually they benefit comorbidities. What I mean is if there is coexisting depression, anxiety, it's easy to treat that, but not these core conditions. Coming to specific management points for somatoform disorder. So if you have to try drugs, it's usually SNRIs, serotonin and norepinephrine reuptake inhibitors, venlafaxine, duloxetine, which can be tried, which have some evidence, and tricyclic antidepressants. Psychotherapy, what helps is relaxation training, and it focuses on modifying a person's thoughts and behaviors related to symptoms. So if you feel that this person can benefit from some psychological interventions, make a referral to a psychiatrist who will then either do these interventions himself or herself or refer to a psychologist. Illness anxiety. Yeah? Again, the drugs that are used commonly are selective serotonin reuptake inhibitors like escitalopram, sertraline, fluoxetine. We also have tricyclic antidepressants like amitriptyline, imipramine. And if this has some amount of, you feel a delusional nature to it, where a person has firm belief that he has, it's not just a worry, but it's a firm conviction, like almost a delusion, one may also try antipsychotics. Do not hesitate to refer to a psychiatrist if you are confused, or at least a consultation or an opinion. Right? Psychotherapy is what is called as cognitive behavior therapy, and it focuses on the misinformation and cognitive distortions. So if you try to explore the history, you may find that patients with illness anxiety have a lot of misinformation about their symptoms, a lot of wrong beliefs about their symptoms, right? And in therapy, these beliefs are tried to be modified. Finally, coming to conversion disorders, right? Here, pharmacotherapy, again, as we said, it's mainly for if there is comorbid anxiety or depression, it is effective then. But for conversion disorder per se, drugs usually don't work that well. What is the first line of treatment is psychotherapy, right? As I've said, reassurance. That, if you see most conversion syndromes, they have an acute benign course and they may remit spontaneously, right? So just giving a reassurance to the family and patient that according to us, there is no major illness, no major physical illness which we need to worry about, right? There is an illness, but doesn't seem to have any benign, it seems to be a benign one. It's not something which we need to worry about at the moment. Just telling them that tests are normal and symptoms will improve is usually very helpful. We can give them some relaxation training, and therapy will usually focus on improving self-esteem, capacity for expressing their distress and assertiveness, right? Physical therapy, especially if there are motoric symptoms in conversion, it's important that you refer for physiotherapy. Why? Because if a person continues to have those symptoms for a long time, for in chronic conversion, muscle contractures may develop. So physical therapy becomes very, very important here. You must have seen that most of the drugs are common for both somatoform, illness, anxiety. So I've made one common slide for monitoring side effects. The most common side effects with these group of drugs is gastrointestinal side effects, nausea, epigastric burning, constipation or diarrhea, right? In patients who are at risk, when I say at risk, I mean people who have some history of bipolar affective disorder, right? So you must have heard of manic symptoms when you go through a psychiatric clinical posting, right? So try to take a history of any episode in the past where a person would have had episodes of over cheerfulness, been very confident, more than usual, been more talkative, right? If there is any history like that, one has to be very cautious because these drugs, all these drugs can increase the risk of having a manic episode, right? Can cause a switch. So one has to be careful, or even if there's a family history of bipolar affective disorder, one has to be careful while starting these drugs. You may still go ahead and start the drug, but you'll have to inform the patient about this risk that he has, and if any of these symptoms come, he has to immediately come back to the doctor, right? Then specific side effects with SNRI, hypertension, sexual dysfunction. With SSRIs, again, sexual dysfunction, hyponatremia. Very important to note sexual dysfunction because it's quite common and patients often feel uncomfortable discussing. So it's important that we ask them, right? And this is a major cause for leaving medications abruptly, right? They may fall out of treatment because of these side effects which they may not tell you. So if you actively ask, we can address it. And with tricyclic antidepressants, one has to know that it can cause a lot of sedation. So inform the patient that at least in the first few days he or she will experience a lot of sedation. Anticholinergic side effects like dry mouth, constipation, alpha blocking effects, especially orthostatic hypotension, giddiness, right? And in overdose, it can lead to arrhythmia and seizures. So one has to be cautious while prescribing TCAs, especially if person has some history of depression and some suicidal risk. One needs to be taking care of these factors, right? So that was a short presentation on these very commonly seen clinical scenarios, right? And these are the two books which I have referred. You all can also refer if you all have any doubts. So I'll just summarize what these three disorders are and what are the management principles. So we saw that all these three disorders have a common thing, that is they come with physical symptoms, right? These physical symptoms do not seem to fit into any of the known medical syndromes, right? On investigations, you don't find anything significant, right? But there is a lot of, when it comes to somatoform, there's a lot of worry, a lot of distress about having these symptoms. With illness, anxiety, the person may be worried that he's having some serious illness underlying these symptoms, right? So that is what is common to all these three disorders. We also saw what differentiates somatoform from illness anxiety is. In somatoform, people focus on symptoms. In illness anxiety, people focus on having some underlying illness, right? Another important point to note is there may be an actual physical condition which is comorbid with these symptoms. And that is why a detailed history, examination, investigations are very important to rule out these comorbid conditions. One should not get carried away because of patient's anxiety, patient's preoccupation with the symptoms, right? Doesn't mean if a person has somatoform illness anxiety, he cannot have a medical condition coexisting with it, right? So we need not always have medically unexplained symptoms coming as somatoform illness anxiety. When it comes to management, we saw the importance of a thorough history, detailed examination, investigations whenever indicated, right? Role of pharmacotherapy, how limited it is, and it is more of psychological interventions which should go hand in hand with your drugs. Right? Thank you for your patient listening.